Recent media attention. We're nearing the end, guys. So unfortunately, a lot of people rely on the New York Times, and you know, they do cover things, and it's good and bad. It brings things to attention, but they can be one-sided. And these are just a smattering of articles that I'm sure you all have followed, and concerns, red flags. What I would say about it is a lot of them have dealt with, and this guy is Barry Meyer, so he's done. Yeah, I've spoken to him, and I don't know what to make of. He has, I don't know, I think he has a very focused view on this. Unfortunately, a lot of it is, I think, colored by total hip replacements. So as Ian brought up, total hip replacements, I think, are a different animal than hip resurfacing. And then a lot of it has also been colored by bad implants. So if you've seen bad results, and the Johnson & Johnson ASR has really been a disaster for hips in general, and especially hip resurfacing, then he's focused a lot on that. But a lot of the negative articles kind of gloss over the fact that, you know, a lot of it is due to, you know, these kinds of implants. And once in a while he'll say, oh, well, the Birmingham and other devices are performing okay. Yeah. But in any case, that's been the genesis of a lot of attention. Our orthopedic literature have had articles, is it worth the risk, and things like that. So this was what Ian was alluding to before. This is a resurfacing with 2 pieces. This is a hip replacement, so it's got multiple areas of corrosion. So it is a different animal, and studies have shown that total hips have higher metal levels than resurfaced hips, even when the size is the same and everything like that. Device alerts, this is the British FDA, the MHRA. They've alerted people to metal-on-metal hips and given advice. And our own FDA has done something similar. But as I was saying, many of the articles lump total hip replacement with hip resurfacing. And as I said, the metal levels are higher in total hips because of the chance of corrosion. And just remember that bad implants were the cause of a lot of these articles. So not every implant is the same. Unfortunately, the negative media has caused many patients and surgeons to believe that all implants are bad, and surgeons have stopped doing it, patients have stopped looking for it, and fewer surgeons are performing hip resurfacing. So, and it's something that needs to be done frequently, I think, to be good at it. So fewer people do it, so more people are going to specialized centers, as I've been fortunate to have. One positive thing I would say is that the media has highlighted the importance of regular follow-up. So you shouldn't disappear for 10 years. You should come back. We should get x-rays every couple years, check your metal levels. And it's like bringing your car in for inspection. And it's just so we could see if there are any issues with that and intervene earlier before things become too serious to fix. Are women different? I think this is the last section. So are women different? Clearly, clearly the answer is yes. This is kind of the first paper in 2008 that called attention to what they called pseudotumors. So the groin is a common area where people will have swelling. They described 12 hips out of 1,300, so to answer your question, maybe about a 1% incidence. They basically described it as fluid-filled or solid mass causing destructive soft tissue lesions, pain, and required revision. But this is the Oxford group, so they have a unique experience there where they have many surgeons doing surgery, and a lot of them are trainees. So this is the one where a lot of the implants were malpositioned, and maybe obviously that we know leads to problems as well. So 1% may be the percentage, but that may be an overestimate also. But that's basically what had led to a lot of the articles being published. Recently, I think people wanted this addressed, was this JAMA article, Sex and the Risk of Hip Implant Failure. This represents the Kaiser experience from 2001 and 2010. So it is a very large number of patients, and Kaiser Also is able to keep track of their patients pretty carefully. In this, women have a 2.3% all-cause revision rate compared to 1.9% of men at 5 years. And this is total hip replacement, whatever the bearing surface. But the greatest cause for revision was dislocation. So we've already talked about that the known fact that women are a greater risk for dislocation. So, perhaps dislocation is the confounding factor here. So,
is that the inherent Q angle?
It's not just the Q angle. It's laxity in the tissues, muscle strength, ball size. So a greater number of women had smaller ball size due to smaller bones. So we already know that ball size is related to stability. So if you have smaller ball size, you're more apt to dislocate. So yes, I think there is a difference between women. You see it's not a huge difference, but this grabbed a lot of attention because it showed there was a gender difference. In terms of hip resurfacing literature, with hip resurfacing in women, 5,000 resurfacings performed by 141 surgeons, so a very large experience, which is good in some ways because it's generalizable. Overall revision rate was very good, so 3.6% at 7 years, but women, again, had basically a double the revision rate. So again, there's a higher rate of allergy dislocation and implant loosening, but also keep in mind these papers are written after the media and people started looking to revise these, so it's hard to tell, but I do think there probably is a higher rate.
This says 141 surgeons. Are there any registries which actually break it down by surgeon? So if you took the top 10 in England,
right,
and took that same stuff,
right,
will they come even close?
Well, that's a great question. The question is, if you break it by surgeon and stratify it by surgeon, and obviously experience has a role, would the results be different? And I would say absolutely, definitely. Certainly specialists are going to have better results, I think. The Australian registry does break it down by experience, so they did find a significant difference in surgeons who performed less than 30 a year compared to surgeons who did more. This is the Registry of England and Wales, so they have over 400,000 hip replacements, over 30,000 resurfacings, and women compared to men, again, about double. Again, keep in mind this is during the whole height of the hysteria, and also a higher revision rate than total hip replacement. But as I said, I think many of you have seen what I wrote in response to this just for my patients. It doesn't account for function or complications. So if you have a hip that works better and dislocates less, perhaps it's still worth that slightly increased risk of revision. And that still means that 95% didn't have a revision. Just to finish up, we did a study also. The United States FDA mandated that we do a study. I'm part of that study. So our FDA mandated that we do a study. And this, our breakdown, we have 293 hips. The majority are men, because men just develop arthritis generally at a younger age with the cam impingement. So most of them are done posteriorly. Survival rate was quite good. So our survival rate was about 97.8% at 5 years. And we also did find a different rate between men and women. So the men are at the top, the women are here, and it was 99% survival for men, 95 or so for women at 5 years. Again, keeping in mind the time frame of this study. So the confounding thing, of course, as we talked about, is head size, and we definitely found a difference in head size by gender. Women average about 45 millimeters, and men average about 50, which, as you saw from that Australian study, was kind of the cutoff that they had. You asked about other data. So this is Derek's data. He was kind enough to lend me this data. This is his data from 2012, looking at his results. He's had the longest follow-up, so here on the x-axis here, we have 10-year follow-up with figures, and now slightly over 14-year data. So his data is incredible. So it is excellent, but he does find a difference between men and women also. So if you look at 10 years, definitely men have a higher survival, women about 95%. And then at 14 years, the survival is lower, but again, these are all patients in England, and they may have had revision because they didn't want to deal with the metals and things like that.
What's the mode of failure? Is it license? Is it loosening?
It doesn't stratify it. These are all cause revisions. So it could be infection. It could be somebody who fell and broke their hip, things like that. Implant survival in men, stratified by age. If you're over 60 or under 60, these are the results he has at 14 years. So they're excellent, outstanding results. And interesting, the older men did better. And there's probably related to maybe it could be activity. Yeah. Right. Judgment. Judgment. That's right. That's right. Better judgment. Older men. They know. So this is the McMinn data for women, so broken down by age. So 10 years, quite good results. Still quite good at 14 years, especially in women over 60. So again, the older women did better. And the interesting thing with that is that it's probably, the confounding thing here is dysplasia. So if women have dysplasia, they're younger. They had arthritis younger, yes.
Just a question about this. The age is age at implant?
Yeah, that's what I was
wondering. Or age, I mean, as they get older, do they change?
It's age at implantation.
Age at implant,
yeah,
okay.
Right. Right. Okay. So women do have different results than men with hip resurfacing, and we've talked about it. Smaller bone, implant size, higher incidence of dysplasia. Osteoporosis could be an issue, especially with hormonal changes. I think greater flexibility is a culprit also. I mean, it's a blessing to some, but it's also, it brings the implant edge to edge, and that can create more metal. So, women's pelvises are structured differently, and that can be an issue. There also seems to be a higher chance of the metal allergy. So that's certainly something that we still really need to do more research on. And that being said, I would say the majority of women do extremely well with hip resurfacing and would definitely benefit from the enhanced joint stability. And these are just some patients I've been fortunate enough to know. And of course, Vicky and Lori. So Lori's demonstrating motion and things like that. So this has really caused, though, the rate of resurfacing in women to go down, which is good and bad, I think, but that's kind of the trend in Australia. So what does the future hold? I think clearly we realize that metal is the problem, and we'd love to investigate other materials to eliminate the metal, but ceramic is a possibility, but currently not strong enough. Here's a fractured ceramic implant, and squeaking will be a concern with that. It might be something where we go back to metal on plastic. So the newer plastics are better, and they're certainly attached differently. So the problems that were seen in the 70s might not be an issue any longer. So we'd love to get rid of the metals, but we certainly need to do a lot of research in that before we start putting it in patients. And of course, we need to really understand what causes allergic responses and develop a test for it. That's really what perplexes me the most, I think. So in conclusion, hip resurfacing is an alternative, excellent alternative to total hip in those patients who will wear out their hip because of age or activity. Patients requiring a more stable joint would certainly benefit from the larger ball in resurfacing. Male patients with osteoarthritis under the age of 65 have the best results. Women can do well, but should have good bone quality and size. Not all implants are the same. And surgical technique, implant position are critical. Metal allergy is still a concern, and absolutely need to continue to research that. So I thank you really very much for this opportunity, and sorry it was so long.